Today, we are honored to have Farbod and Jonathan here. Hi, Farbod. Hi, Jonathan. Welcome. Uh, yeah, how do you pronounce your company's name? Is Trillium Health Partners?
Exactly.
Trillium Health. Great. So, so today we're going to talk about Farbod and Jonathan are going to talk about solving the infrastructure, solvings for infrastructure thoughts to cloud. Farbod is a data scientist, software engineer, and technology leader. He is an adjunct. He's a professor at Della Lana School of Public Health, and he led the team in the design and implementation of a healthcare data science solution in 8 different hospitals across 4 different provinces. We have also Jonathan here. He's a project manager and project lead with Trillium Health Partners. He has a background and interest in process engineering and operations research, and he brings a unique change management perspective to the impacts of machine learning on healthcare processes. Farbod and Jonathan are concerned about implementation gap that prevents AI algorithms from having a real-world impact on patients' care. This failure can be caused by a number of factors, including addressing the wrong problems, poor design, lack of access to the right data, lack of appropriate infrastructure, and AI algorithm degrading with the time. So guys, we are so thrilled to have you here. The stage is yours. And thanks for being here.
Thanks so much, Razi. I'll kick us off. Let me share my screen here. And thanks for that kind introduction. We are from Trillium Health Partners. For those of you who are not from Ontario, Trillium is a health system based out of Mississauga and Brampton. It's just sitting outside of Toronto. And this, as Razi mentioned, it's the talk today is around our journey, if you will, towards the deployment of an AI algorithm. And really solving for data infrastructure through the cloud as the bigger theme, if you will. So I'll start off the presentation. I'm going to kick it off to my colleague, Jonathan. We are both from the Institute for Better Health within Trillium, but we'll tell you about that shortly in a second. So with that said, just to give you a sense of the agenda for today, we're going to start talking about who we are, a bit about Trillium. Then we'll talk about some of the problem that we tried to solve and that we're presenting to you about today. Then we'll go through the actual content of the presentation, which we've broken apart into 2 sections around data science side of it and then the cloud deployment side of it. So this is we decided we'd start this a bit differently. We're almost starting with our results. So this is kind of the end result of what this whole talk is about. This is what we did. So what we ended up doing is we evaluated 4 different statistical models on this problem of census, which we'll tell you about shortly. And the final output is really an automatic report that gets generated daily and gets sent to decision makers within the hospital. And the AI algorithm is what's really empowering and producing the predictions that is being sent out. So we'll talk a bit about the data science and the machine learning side of it. Then we'll talk a bit about the cloud side of it, the how, which is what we ended up doing is actually deployed this project as a proof of concept on the clouds in collaboration with the UBC Cloud Innovation Center. Because of the time constraints with the talk today and just a format, we are not going to go too deep into the weeds, but we do have a technical blog. I believe this presentation will be available after. So feel free to browse that blog. It'll give you all the resources that you need, but we'll talk through it quite a bit today. But if you want more, you can always browse the blog and read it in depth. So to talk a bit about Trillium that I mentioned, for those of you who are not familiar with, we are one of Canada's largest hospitals. So we have over 1.7 million patient visits a year. We have the #1 surgeries and procedures each year with over 72,000 of them. As you can imagine, being based out of a very large community such as Mississauga and Brampton, we have a very high number of emergency visits. and we serve the entire population of Mississauga, Peel, and Halton, which is around 2.2 million people in total. And you can see we cover the full suite of medical procedures. So we cover all the way from emergency care to cardiac and cancer care. What makes Trillium quite unique, other than the situation, the location from which it's scheduled, or it's located rather, is the amount of investment that the hospital has done in the data infrastructure. So you can see consistently year over year, there's been very, very large investments made in terms of making sure that the data assets are kept up to date. So the two most recent ones that I'll draw your attention to is that Epic, the EMR, was launched in 2020, and before that, there's a brand new PACS system in place. So it's really it's amazing to be working with end of the line, if you will, equipment. Just to give you some context in terms of why we're talking about the census problem today, Trillium, because of, again, where it's located, there is a very large amount of growth in population expected, 45% to be specific, by the year 2041. So the hospital needs to respond very quickly and very efficiently to this demand. And that's really the bigger context around some of the work that we will be presenting today. For those that are not, again, from Toronto, Mississauga is a very, very diverse population, which is one of the most amazing things about working in this field of data science here. As we've covered, there's the projected 20-year growth in patient demand you'll see us on the red dot in that graph on the top right. It's way above and beyond what anyone has expected, and it's extremely diverse, the population that the hospital serves, which is that entire region that you'll see on the map there. Jonathan and I are working from the AID lab, or the AI Innovation and Deployment Evaluation Lab, within the Institute for Better Health. How we like to tell people about it is, companies all have R&D departments, but R&D is very rare in the healthcare industry, where consistent investment in research, not in a grant and project specific manner, but in a consistent manner, is very rare. And that's what the AID Lab and IBH, Institute for Better Health, as a whole, are trying to do. So what we're building is a foundation, really, for AI evaluation and deployment, where we're really trying to rigorously evaluate a lot of algorithms that are out there by evaluating them in one of the most diverse populations in Canada, and really combining that rigorous research lens with the real world evidence gathering lens. So what we're at the frontier of sitting between population health analytics, operational analytics, and clinical system analytics. That's the lab that we're from. We have some of the photos of the amazing people that are at the AID Lab. We'll do acknowledgements later, but of course, a million thanks goes to all the folks on the screen who basically made everything that we're talking about happen, and are continuing to push forward and innovate. Jonathan and I are just representatives here presenting the great work that the bigger team has done. And with that, I'm going to hand it over to my colleague Jonathan to take us through the hospital context.
Awesome. Thank you so much, Farbod, for that larger context. And as we prepare ourselves to kind of think through the hospital issues that happen day to day, now we spoke to some of those strategic challenges with growth in our population, but our problem has more to do with operational challenges. We can go to the next slide. One of the hardest things with managing, I guess, a data science portfolio is being able to determine, are you working at that strategic level, tactical, or are you working at that operational level? When it comes to operational problems, these are sometimes hard problems to solve, because your operations, as it matures, its processes needs complementary insights to be developed. And what we see on this screen is just a view into the complexity that is required to operate a hospital of our size. We have on screen, there's the ED, inpatient, and critical care units, and each of them go through a 4-tier stage of reaction, more better, or proactive changes in their capacity, the number of beds that we are operationalizing for the census that we have in our hospital. Green is regular operations. Yellow would be, we're starting to increase spaces for people to reside in. And then red would be we are starting to get over our comfortable capacity. And then there's a gray zone where there is other communications that have to go externally outside of the hospital. This map provides a sense of what the operational leaders need to do. Are we going from green to yellow? Are we going from yellow to red? And what do we do as a result? So this is based on a capacity decision, based on census that exists in the hospital. Of course, this is very relevant to a time of COVID, and these policies are hospital specific because we're dealing with operational challenges. Tying our data science to a process is essential for being able to influence a hospital. So I'll go to the next slide. Our business context has as follows. There is an age-old supply and demand of beds and staff to patients. This is an age-old problem that every hospital always is going to struggle with as they develop their processes operationally and their technology. We are no different, and we wanted to be able to have a view to surges that were in the near term for our hospital, specifically in that mapping onto the different functional areas that leaders need to respond to, the ED, inpatient units, and CCC, the critical care teams. When we start our project, when we think about this big challenge, we really want to just dig into our main decision maker. And so we start our project, and this project specifically, with user stories, sessions where we gather information from leaders. That leader for us was a director from patient flow and registration. So when we start a project, we really need that high level buy-in, not the operational managers or below. We need that director level or above to say, this is what is important to you. And what was important for our director was to be able to have a view to flow challenges few days. 3 to 5 days was what we were mandated to be able to figure out. And we needed that exact number because we needed to translate that into requirements for our modeling. Why is census prediction so important? For our user, census gives them a sense of focusing their energies on, do I start operationalizing beds because that takes days and has lead time, or do I focus my energy elsewhere? Now, we took that and we started to iterate and started to design and started to improve upon existing reporting tools that existed in our hospital. So what we did was we built further model. Our goal was to build better models and evaluate a plethora of models to be able to make better recommendations for our leaders on their operational processes as we co-design processes with models and insights together. And finally, we want to be able to push this all to the cloud. So just to give you a bit of a framing for our work, we'll go to the next slide. We are going to discuss this in 2 phases. I think giving that context from a data science perspective is going to be super important in all the work that we did on premises. And one of the challenges that we did to, which Farbod will speak to, is there were challenges in working collaboratively. There were challenges in terms of getting the right infrastructure, that deploying our work to the cloud really enabled our data pipelining to be able to connect to the cloud, which is also really important for leveraging much more technology that is now readily available. So we'll go through that context. I will go through that phase 1 context, and Farbod will talk about the benefits and the results of going through a cloud infrastructure for deployment of this model that we determined. So data science on-prem. Getting data from a hospital in Ontario can be really challenging because of the functional groups that exist. Just data acquisition alone, there are decision support teams, business intelligence teams, and then a host of information systems teams that you have to work through, the database administrators. Are you going to leverage the previous ETL packages, or are you going to go straight to enterprise service bus? Where are you going to get your data? This is the first phase of our work in terms of our business requirements. We sourced all of our work from the electronic health records, and we did so for 4 years for our analyses. To better understand and give context and have a design session with our leaders, we worked on a lot of exploratory data analysis. We treat exploratory data analysis as just as a more of a consultation, a co-design for our later model development, because we really want to make sure the model we're building is the right level of accuracy, so we don't continue to do too much work, because we can only respond so much to a model prediction. So an additional 1 MAE, for example, may not be the make or break it for this leader. And so we really needed to do exploratory data analysis to determine that. For the models that we decided to work with here, we did a persistence model as our baseline. Now, I know this sounds super simple, but time series, we typically jump ahead before doing a baseline, and we don't realize that sometimes the previous day's prediction may be good enough for tomorrow's prediction. Not everything's exponential growth, and recognizing that is super important from a machine learning ops perspective, because we do not want to maintain difficult models, especially from an operational standpoint, especially with primarily on-prem infrastructure going to the cloud where your agile practices are immature. We additionally had a specific THP tool which predicted admission prediction with probability distributions. We had a Serema model, which is very common in time series, as well as we used a Facebook Profit as well, which is an open source package just for time series prediction. All of these we mapped with mean absolute error as our evaluation metric, and I really want to make sure this is key. We are coming from the angle of impact to users, and impact for our operational users. They needed to know that an additional mean absolute error of 1 meant one other patient that you need to care for. We could not have complex metrics. It had to be directly relatable to that user, and that is the best metrics for that difference in lingo that happens between our tech team as well as the operational team that has to do something in the hospital as a result of our recommendations. So that was why we anchored onto these metrics. We can go to the next slide. Just to give a high-level perspective, we looked at overall trends within 4 years and determined based on those operating documents. Now, we don't make the operating documents. We solicit them, we get them, and we say, here is how you're performing, and here's what your definition of surge is. Now, operations folk, they don't think statistically. They're not going to tell you this. You need to show them and help define for them what is a surge for them in their operations. So it's a bit of a joint design session here. And what we used these diagrams, especially our box plot charts, were determining when would a decision be made. Would you make a decision about increasing capacity at the beginning of the week or the end of the week? And it turns out it has to be at the beginning, because that's when you have the capacity to operationalize. So our predictions have to happen Monday, Tuesday for an end date of increasing capacity over the weekend on Thursday, Friday. So it has to happen because of operational constraints. Now, this is all part of soliciting feedback and making sure that our tool and our report has impact. And so this is one of the many plots that we use to be able to tailor our solution for our user. We'll go to the next slide. Now, this may be kind of scary for those who do not work in operations for a hospital. Maybe you would prefer I have one box that says hospital, input, output. But our hospital has, as you see in the top here, birthing walk-in, birthing registry, C-section scheduling, surgery scheduling, emergency department, clinics, the like. There's so many places where patients come from into our hospital, and this is for just one of our sites. And we have a lot of different places that the patients end up staying, and they transition and transfer from one location to another, and they end up going home or ALC destinations. ALC is alternative level of care. There's a lot of places they go. Now, when we need to determine a census prediction, we need to determine a census boundary, a system boundary, to be able to start modeling around. And we have to determine categories of census. Now, these are where the patients are. We can do the overall hospital, or we can do subsets. Now, for us, we want impact for our users. So what made sense was not just physical locations, but grouping the different census based on decision makers. And our decision makers are organized by mother and baby, planned care, unplanned care, mental health and rehab. We have decision makers under those categories. So although they manage multiple locations, we want to make sure that they are being reported on based on their decision-making hierarchy that is intrinsic to our hospital. So this was a blueprint, a schematic that led into mapping to clinical systems and being able to determine data elements that were necessary for us. It was a translation tool, so to say. We'll go to the next slide. As a operations researcher, I need to start with a statistical control chart. I am not going to build a model unless I know where my variation is coming from. And this was a great place to start. Statistical control charts are providing you with no model heavy, just an understanding, and you can do a moving horizon view of this. Where is your deviation coming from our planned care, unplanned, mental health, rehab, and mothers? I'm not going to go into the details here, but I'm just going to highlight one thing. The coefficient of variance, which describes the relative change within one of the variables, is the highest within our planned care. This is consistent with literature. Planned care is we plan to have a surgery, and our volumes change a lot. There are many reasons this happens. Primarily, it is scheduling over the weekend. That is one of the hardest challenges within healthcare. We always schedule a lot on Monday, Tuesday, Wednesday, and then Saturday, Sunday, we don't have much scheduled. This is an Ontario problem. This helped us understand that we should take apart the aggregate site level prediction and break it into some constituent parts, because we could aggregate back up to the site and we can model separately these different functional areas, both because the report readers want them, but also would provide us a flexibility in modeling these different processes slightly differently. I'll go to the next slide. Now, I'll close by with these results that I've summarized quite a bit here. On the right-hand side, we have a simple ranking. We performed multiple models. Persistence, our custom probability distribution version of our tool, Surima and Facebook Profit. It turns out per different functional area, our THP tool did great. Surima actually performed really well, or actually comparable to almost all of them except planned care. And rehab, it worked best with persistence, just like yesterday was like the same as the next day. What the principle of selection for us became, especially from an ML ops perspective, was we need to maintain this model. We need to make sure it's flexible, it's resilient. We found that our THP tool, although it was the best on one cut, as COVID came, we ended up having challenges with it for maintaining it and continuing to tune it. We ended up steering a little bit further towards using Surima as well as persistence as our go-to models from a maintenance perspective. The left-hand plot, I won't go into detail, but a lot of Nature papers, they end up having this cumulative error description just to help communicate to stakeholders. This is cumulatively the error that you start seeing. Primarily, we did this for communication to our stakeholders, so they visually see how error accumulates differently for these functional areas and how wrong we are. So they acknowledge as well, we're not perfect, our accuracy can't be perfect, but here's relatively how good these different algorithms perform over time. And if there's any spikes, we can comment towards that. We can go to the last slide. For myself now, we, as a result of this, have this report going out daily, and we are able to give a few different features. We are able to predict admissions, discharges, census. We're also, as per our users have asked us, being able to superimpose our predictions with our historical trends, and also be able to speak to how this impacts the operational policies. At the top header, we really need our leaders to be able to say, is there a high, low, medium risk of going to another green to yellow, or yellow to orange, or orange to gray, for example? So we really needed these, and this was a very co-designed set of sessions to get this tool that is bespoke for our institution. So Farbod, I'll hand it off to you as you now speak to what did we do to get this to the cloud?
Thanks, Jonathan. So I'm a bit mindful of time. So what I'm going to do is I'm going to focus on the key concepts. Like I mentioned, I'll direct everyone who's interested to go to the blog that we showed earlier, and you'll find on these slides where all the details will be. But let me just start by talking about, well, why even bother with the cloud? As our team focuses quite a bit on innovation through research, a really big factor for us is the ability to be able to prototype very quickly, and ideally not with a ton of cost. And that is one of the biggest things that the cloud, having access to a cloud environment enables for us. So if we were to do this on-prem, we would have had to invest on some local compute capacity that would have to be delivered and configured, that have to be ordered. So you can imagine the amount of time would be involved would be extended. And because of the fact that we're ordering a machine really long term, there's quite a bit of upfront cost. Whereas this can be, an environment can be quickly spun up on the cloud in a safe manner. So that's a lot of the work that we did with the UBC Cloud Innovation Center, was really spinning up that environment in a safe and secure manner. So this is the eventual architecture that we built. I'll briefly again speak to it, and then we'll get to our lessons learned. So what is happening here, and I'll draw your attention. So let's start here with our on-premises enterprise data warehouse. On a daily basis, Delta data gets pushed to, in our case, because in this proof of concept, we're using Amazon. This is an S3 bucket that it gets pushed to in a staging environment. And then a number of glue jobs run that move the the data through the various levels of refinement, if you will. So this is our, we're building out our data lake here using S3. But that's the glue jobs are responsible for moving data throughout. And of course, everything is being cataloged as we're building this data lake through the glue data catalog. What I'll mention is how the actual work happened is we actually did quite a bit of the training in a SageMaker environment, which is, as some of you might be familiar with, is basically a Jupyter notebook in the cloud, which is one of those key things around, again, going back to why the cloud, is that enabled us to be very collaborative. Where it was very hard to share code and share data and have that replicability on-prem before, this is one of the things that going to the cloud and prototyping quickly solved for us. You'll see it's a bit of a serverless type of setup. So since the data gets updated every day, a Lambda function gets triggered, which then runs the model that Jonathan alluded to earlier and spoke to in detail about. We've Dockerized that environment, if you will, Dockerize that model, and that's how the work gets done. And now when everything is done here, we are using a script to produce a report. Again, Jonathan showed you guys the report. That then gets sent out to the users through the simple email service that, again, AWS offers. This is a very high level architecture that we're going through. Again, I would refer folks, we went through in detail each of these 5 items that I have on the screen here around what challenges we had around security and identity, what around data ingestion, what challenges we had, and what the key lessons learned were in each of those buckets of work. But let's go to the actual lessons learned slide. So I'll start with the data science portfolio management. Really, as I mentioned, our goal has always been to start small in the cloud with proof of concepts. As you can imagine, in a hospital environment, a lot of folks, like Jonathan mentioned, have to be brought along, and there has to be lots of internal capacity building as well as we're introducing totally new tools to the enterprise. From a model building, I think Jonathan covered this already, so I won't touch on that one as much. But I think on the cloud deployment, what I'll say is, again, like Jonathan is mentioning, a lot of the cloud native tools that abstract away a lot of the complexities of managing systems, it just makes it a lot easier to deal with operations in a much less resource intensive manner, and lets people, and it allows for prototyping to be done quickly and tools to be enabled. So that was really one of the biggest takeaways that we had from this whole cloud environment. I know we're at time here. I wanted to take a second to put all these names on the screen. Jonathan and I, as I mentioned earlier, we're only here representing the bigger group, but the work wouldn't have been possible without these folks. And I'll wrap it up here. If you want to join us, please do reach out. I know you have access to the to these slides. And again, we put the blog down there if you want to read more about some of our specific technical challenges that we had and some of the lessons learned there. And I'll wrap it up. Thank you so much.
Thank you, Farbod and Jonathan. It was great. We have a couple of questions in the chat. First of all, regarding the slides, video will be available after the session, but we're not going to share the slides. There's a question about the cloud you're using. So they're asking about why UBC and not GCP or AWS or Azure.
I can briefly speak to this, and I'll ask Jonathan to jump in. Because we did this, we were actually we found out about this amazing initiative, as I mentioned, with the UBC Cloud Innovation Center to do this. So they work closely with AWS, and they enabled this whole work through this proof of concept. We have not we have not procured a platform yet. So we're not commenting on GCP or Azure or AWS. It's just this proof of concept happened to be through the work that we did with UBC Kick. Jonathan, anything you want to add there?
No, I think that's exactly it. It was more opportune in terms of the partnerships that we could be able to develop. I think in healthcare, it's so important to continue to be able to develop those partnerships because there's a lot of expertise around different tables. It's just about bringing those people together. And so UBC Kick gave us a lot of expertise to just upskill our entire enterprise and increase our capabilities for future work.
Great. There's another question about, it says, is this trauma hospital? If it is not, how does your work compare to what you'd have to do in a trauma hospital?
Great question. I think it's maybe like a system boundary sort of framing. So no, I didn't deal with any trauma component of the Trillium that I don't have any knowledge of. What would change primarily would just be some of the transfer and admission components. We wouldn't be dealing with anything clinical here. We're focusing on operations. So I would say if there was a trauma component, it would depends on how the leadership is organized. Our focus on this tool is how we can enable those leaders to do their work better. So the best that I can maybe approach the question is a bit of a tricky question.
Thank you. Anne is asking if you can post the blog address in the chat. And there's another question. Thank you. Another question from Katrine. It says, how are you addressing PHI in the cloud?
Jonathan, do you want to take that or do you want me to take it?
Good question. So for PHI in the cloud, this was and I see one other question with the IT team. We were very heavily involved with our security and privacy teams. This was a very good opportunity to co-design a lot of processes internally in our enterprise, because there was a lot of tools for anonymization that we were able to leverage, as well as being able to determine and better understand data security to the cloud, in the cloud, and of the cloud sort of model. So we were better able to categorize these and establish more rigorous cloud policies for our enterprise and better thinking around this. So I think PHI in the cloud is not the primary concern. It is about like, how do you manage risks properly as an enterprise? And so we were able to flesh those details out. And I think as an enterprise, it's a collective experience there. You need to be able to work on that sort of definitions together. And sometimes we get stuck on those works. I think working on small proof cases like this one is a fantastic way of figuring out how your institution is going to do PHI in the cloud.
Thank you. Joseph is asking, so cloud is the way to go, and also security is better than on-prem since the CSP applies best of breed, right?
I mean, so I'll speak on my personal opinion. I am a big proponent of the cloud as the way to go. But like Jonathan mentioned, there's a lot of work that needs to happen to bring it to the enterprise, and both internally make sure everyone is aligned and those new processes are established on the cloud, because of course the enterprise knows how they're governing data locally, but then similar patterns have to be developed. So that's why we're doing it one proof of concept at a time and trying to establish new patterns, for example, for de-identifying data, for moving data securely, all those things. That's why we're doing them one POC at a time to try to bring the enterprise with us. I hope that answers the question.
Thank you. Then another question about automate bed assignment. Is the goal to automate bed assignation?
That's a great question. So although I was framing earlier discussions around the operational, tactical, and strategic would have been, are we going to get more beds in our hospital? Are we going to build a new building? And so those are strategic questions. We dealt with the tactical question, which was, do we want in like a week time to like increase our capacity slightly? Getting to that truly operational question of like, where are you going to go? Are you going to go to this bed? Are you going to go to that bed? That was outside of scope of our work right now. The impact for us was less for our particular user. So I think it's based on a user need at the moment that we do have entire teams dedicated to do that in a more manual process at the moment. Unless the need presents itself, I don't think that we have that in our vision at the moment.
Thank you. There's another question that asks about seasonality effects. How is seasonality affects traffic?
I can try to take that question. I'm a little bit confused by it, but the only thing is just a bit of the grammar. I think, how do we account for seasonality? Maybe that's the question. And well, we worked on a lot of SARIMA sort of analyses, autocorrelation plots to be able to determine the best seasonality factors. There's like P and Q values that you typically derive when you're doing seasonality trends. So we did a lot of that in the upfront exploratory data analysis. We did that as well with a lot of our user engagement. We found good models for Surima that accounted for the seasonality, and that's how we managed it. We did find that other simpler models that don't encounter the seasonality, that have more short time windows, were performing comparably to the models that we considered the seasonality effects. So we had considered it in some models and then used it for discussion points for our users, but it ended up not being during our implementation, not all that important for some parts like rehab. I'll give as an example.
Thank you. And I think it's the last question. If I've missed any question, guys, repeat your question in the chat. But there's a last question that says, how large was the IT team actively working on this?
Awesome. So the number of components, let's say in terms of IT team, well, I think active team probably closer to like 5 to 6. Core team consultations would get up to a dozen or more, because just we had to consult with a lot of people from like the tech team side, from integration services and security, privacy, even some database administrators, to be able to work with them. So we consulted with many, but core team is closer to 5, 6 that actively worked on this as one of their responsibilities throughout a time horizon.
And I think we made this point already. Like this is definitely a work in progress for us. We're still evolving. We're still developing more patterns, working through more use cases. So it's exciting work. So we hope folks enjoyed the talk, and if they're interested in joining, please do reach out through the means, through the slides.
Great. And we have another question. So how long did the project take from idea to POC?
Good question. So I think we actively began after COVID. We had started the project just before actually COVID happened. We had to take it off, and then because of changing priorities inside of our hospital, and we started up more actively September and finished everything with respect to the deployment around April. We're still ongoing in terms of some of our rigorous governance for the cloud, because that's kind of the tail end of our work. You realize after going to the cloud that you do need to manage account security and identity management a little bit more rigorously. Our bucket list is what we're currently acting on, but I would say the work we presented today is about eight months of working in a portfolio of other projects as well.
Great. So perfect. I guess we don't have any questions anymore. If you want to add anything, Farbod and Jonathan, you can say now.
Nothing else from me. Thanks so much for listening. And again, if we would love to hear from folks, please do reach out.
Yes, likewise here, echoing that. Thanks so much for listening, as well as hoping that all of your enterprise engagements go well, and as the maturity of Ontario hospitals improves, we hope to hear from you.
Great.